So welcome to the beta blocker toxicity lecture. So beta blocker toxicity. Let's talk a little bit about risk assessment. So beta blockers actually aren't as dangerous as they sound in overdose. They're relatively benign, except for propranolol and sotalol. That's what should have you worried. Now that being said, a massive overdose of any beta blocker is significantly dangerous, but it's propranolol and sotalol, even in the smaller doses, that can cause significant toxicity. Clinical features, of course, bradycardia and hypotension are the top two. If you have a undifferentiated tox patient that's bradycardic, top three on your differential in no specific order should be beta blockers, calcium channel blockers, or a cardioactive steroid such as digoxin. But some clinical features specific to a couple of specific beta blockers, propranolol, it causes sodium channel blockade. So you can get those wide QRS, ventricular arrhythmias, etc. So think TCA overdose. Also causes seizures, and it is very lipophilic, so it cruises right on into the brain and can cause coma and decreased GCS. Sotalol, in addition to its beta blockade, it causes potassium channel blockade as well. So of course that's going to widen out your QTC, cause some QTC prolongation. So keep that in mind in sotalol overdoses. Workup, nothing special, just your standard toxicology workup. So management, a little bit of controversy here. So we do know that you just start with IV fluids, atropine for life-threatening bradycardia, hypotension. Go to your standard pressor of choice, whichever one you're more comfortable with, adrenaline, noradrenaline, etc. But a few specific points in management. We talked about propranolol and sodium channel blockade. So if you do have that wide QRS and you're getting funny arrhythmias or something of the such, you treat that wide QRS with sodium bicarb. So again, think TCAs. Glucagon. Here's an area of controversy. Is it really more effective? You know, it used to be, you look in any tox textbook, and it used to be the first line nifty treatment for beta blocker toxicity. It's kind of fallen out of favor a little bit. What we know about glucagon is that anecdotally there are many case reports that it works. However, it's never been shown to be more effective than your standard inotrope or your standard pressor. We do know that it makes a lot of patients vomit, and we also know that it's really hard to source. You dose it by about 5 milligrams. That's the glucagon rep just texting me telling me what am I talking about. But no, we do know that it's dosed 5 milligrams slow IV push. It can be hard enough to find 5 milligrams in the hospital, much less your ED. So that's prohibitive as well. The textbooks, so Goldfrank's, one of the tox Bibles, still listed as a early treatment for beta blocker toxicity. Murray's Tox Handbook, which I really like, they go as far as to say that it's actually a pitfall to use it as first-line treatment in beta blocker or calcium channel blocker toxicity. What do I think? Anecdotally, I've seen it work in about a third of my patients I've treated with it. I've seen it make over 2/3 of my patients vomit, and it doesn't work in over 2/3. So basically, I don't like it that much. But on your exam, if you do get a beta blocker overdose, you should mention glucagon. It's fine to talk about the controversies that it's hard to source, it makes patients vomit, and it's never been shown to be better than a standard pressor. So anyways, that's a spill on glucagon. We'll do a full lecture on it. Remember, on its mechanisms of action and how it works. So keep an eye out for that as well. High-dose insulin therapy. Is it effective? Is it first-line treatment for beta blockers? Not just yet. It is for calcium channel blockers. The literature's there, but for beta blockers, it's not quite as effective, and it should not be your first line. You should still go to your pressor of choice. Lipid rescue and propranolol. Sure, if you've tried everything else and nothing left to do, give lipid therapy a shot as a rescue treatment. The thought is because propranolol is so lipophilic that maybe it'll help out. But again, that's in the line rescue therapy. Disposition. If it's an immediate release beta blocker that they took, 95% of these patients will show signs or symptoms of toxicity within 4 hours, 100% within 6 hours. If they haven't shown any signs or symptoms such as bradycardia or hypotension at 6 hours, you can medically clear them. That is the immediate release. The sustained release, a little bit different. You need to watch them a little longer, probably 8 to 10 hours. The one caveat to that is sotalol. Even if it's immediate release sotalol, you still need to watch these patients for 12 hours to monitor for QTC prolongation. Just some food for thought, parting words. Hypoglycemia. So test makers used to like to try and have you differentiate between beta blocker toxicity and calcium channel blocker toxicity based on their blood glucose. We do know that hyperglycemia happens in calcium channel blockers. However, hypoglycemia, although it used to be taught that, now we're pretty much sure that's not necessarily the case. Most beta blocker overdoses are euglycemic, except for kids. They can sure get hypoglycemic in beta blocker overdoses, but not really for adults. So if you're trying to differentiate between beta blocker toxicity and calcium channel blocker toxicity just on the blood glucose, probably better ways to do it than that. So anyways, that ends our beta blocker toxicity, and we're on to the next lecture.